Perspectives Behind the Breath podcast series that highlights members who are making an impact in various specialties and avenues throughout the country. I'm Lisa Weisenberger, AARC Director of Engagement and Media, and I'm joined today by Monique Kimmel and Marjorie Cullinan to discuss Marjorie's RT journey and the importance of mentoring. Monique, can you start us off?
Sure. Hey, thanks, Lisa. And thanks, everybody, for joining. My name is Monique Kimmel. I'm Vice President of Membership and Customer Care with the AARC and thrilled to be joined today by Marjorie Cullinan, who is the Operations Manager of Pulmonary Function Testing at Yale New Haven Hospital. We're just so excited to have Marjorie join us today and all of you as well. I'm going to go ahead and start off because I love to hear about people's personal and professional journeys into the field, this exciting field of respiratory care. So, Marjorie, if we could just go ahead and start off from sort of the beginning, and you can let me know and the audience know a little bit, how did you get into respiratory care and sort of what drew you to this profession?
Well, thank you so much, Lisa, Monique, and the AARC for having me for this podcast. My journey into respiratory care was not one that is terribly unusual in that I had no idea what respiratory therapy or respiratory care was growing up. I went to Ohio State University, and I very much went to Ohio State to be a synchronized swimmer. I was an athlete, a swimmer. Breathing is very much part of synchronized swimming, but I was also in a health science exploring program. So it was called Health Science Scholars, which was based in allied health for those who did not know what they wanted to do in particular, but knew that they wanted to end up sort of in the medical world, in the hospital world. So as a freshman, we had to take our regular courses that would be things that were prerequisites for health sciences. And I was in a course, like a 101 level course, introducing us to all the different specialties that happen within the hospital setting. One of which was this professor just stood up in front of the whole group and talked about respiratory care. His name was Herb Douse, and he was actually an author in our Egan's Fundamentals of Respiratory Care. And he just captivated me with all the different things that respiratory therapists do, and then all the different places that respiratory therapists are across the spectrum. So this was in September of 2001. So the towers had just fallen, and there was a lot of need for people in the healthcare field. So I was very inspired by what he had to say about respiratory therapists' contributions. And so he, had introduced the topic, but then also provided us with some opportunities to do things like shadow in the hospital and learn more about respiratory care. So I ended up applying to the respiratory therapy program at Ohio State in my freshman year, and my sophomore year, I ended up taking courses getting me towards pursuing my bachelor's in respiratory. So I didn't have the full intention, but the second that I learned about respiratory therapy, I was captivated. So.
That's a great story, and who would have known? You love to hear these things about people, but how we're going to talk a little bit more about mentoring a little bit further in our talk here. But it's just inspiring to hear that this is what happened to sort of propel you
Exactly.
into the profession.
Mm-hmm.
I know that, or I understand that initially you specialized more in the adult and pediatric critical care in terms of, your earlier career. What was it that attracted you to diagnostics, particularly pulmonary function, exercise labs? What were some of the things, like how did you begin your training? What were some of the ways that you sort of moved from one to the other?
So, as I was working in adult and pediatric critical care in a large acute care hospital, we have a couple of physicians who were really building a cystic fibrosis center and adding a respiratory therapist to the team. I was someone who was interested in cystic fibrosis and was given the project of entering that clinic. When I went into that clinic and saw the ambulatory setting and how complicated things were in the ambulatory setting for patients, and in the corner of my eye could see the pulmonary function lab and all the amazing things that they were doing, I said, you know what? This is something that I want to explore. This is something that I'm interested in. I love the testing and the results and what that means in pulmonary physiology. Um, and then as I was growing in my career and working my way into more of a leadership role, there was a position in the pulmonary function lab as a supervisor. So I applied for that position and luckily was chosen. And I knew very little about diagnostics at that point. Like I spent every evening in textbooks. My team knew way more than I did. I knew how to lead, but I didn't know the physiology. So, Rupel's pulmonary function, I think I have multiple editions of, and they look just absolutely terrible. They're dog-eared and highlighted, and I really dove into texts and into articles to learn about pulmonary physiology and the testing that was being done. I was very lucky to have other RTs that were willing to lean into me being their leader and helping me to learn. I even had a respiratory therapist. He was a very quiet gentleman, one of my, per diem staff, just walked into my office one day and slid me the ATS manual. Like you need to know this. I'm not forcing you to know this, but this is something you need to know. And I read it cover to cover, and just wanted to become a specialist and wanted to be just as proficient as all of my amazing team members in the lab.
That's awesome. And you hear that a lot in this industry, I think, just the amount of teamwork and support generally. So that's great to hear. I know that, I mean, it's so different, but there's a lot that's very, very similar. What would you say were some of the major challenges that you faced sort of in both? So on the acute care side and then versus on the pulmonary side?
One of the biggest challenges is um, being able to take really good care of patients across the spectrum, and patients feeling safe and being able to get complete information so that we can help the doctors with their diagnosis and their treatment. So whether that's taking measurements on a ventilator to make sure you're capturing the dynamics of their breathing or problems with a mechanical ventilator, or having a very, very sick patient needing to do an extremely difficult breathing test. Some of the some of the people that we see in the pulmonary lab actually could be in an intensive care unit just as easily as they are sitting in the chair next to you. And there's nothing worse than bad information or bad quality data when it comes to diagnostics. So, doing your best to not compromise the patient, obtain the best measurements that you can. And sometimes with very challenging personalities or people come in with their own issues and problems. And you now have to work with someone who is very cranky, and give a positive patient experience. Um, that can be quite a challenge, along with sometimes providers have um, expectations of what the patients that they can accomplish that they truly cannot. And that's okay. It's okay to say we're not going to hand in a perfect report card. And maybe that's a reflection of how sick they truly are.
Right. And having that prior knowledge and really can visualize, sort of where they are in the state of
Mhm.
their comfort zone, if you will, with the testing.
Yep.
Um, I know and I've heard in diagnostics that there are some kind of common misconceptions about this specialty. So I'd love to throw that at and see what you think and what are some of those.
Yeah. So I know because at one point I was outside of diagnostics, that many people think that you go to a pulmonary lab to retire, to slow down, to work a 9 to 5, no weekends, no holidays kind of job. And it it isn't that anymore. If it ever was, I don't know if it ever was. When I joined the pulmonary lab, we were this rapidly growing, um, lab, we were adding machine after machine. Technology, it was advancing at such a rapid pace. You really need to know software. You need to know how to fix hardware. Um, Patients are sicker and sicker that we're testing. So we move at a very rapid pace throughout the day. We have scheduled appointments. Those scheduled appointments are with or without a machine malfunction, right? So if something breaks, we need to fix it. And we oftentimes don't have biomedical engineers there who can just, pull out a wrench and fix it, or a vendor that can come and fix it. We fix these things ourselves.
Wow.
Software has advanced tremendously in diagnostics, where it used to be that like one of the RTs that I learned from said that there used to be a dry rolling seal that went up and down with a pencil, and it would be drawing the breathing. Now we have advanced software that captures it, but you need to make sure, as the person with the brain in your head, that that is accurate data that's being displayed. You need to be able to navigate that software and the interfaces between electronic medical records and the software we're using. So it really is becoming a world of um, devices, technology, and you still need to keep your acute care skills, because your patient could have a syncopal episode. Your patient could have a hypertensive episode. I have called 911 a number of times on my ambulatory sites, or very quickly walked with a wheelchair down to the emergency department with
Yeah.
somebody on my hospital sites. Um, so it's if you're coming to my lab, you do not think slow down. You are moving through the day. We do lots and lots of patient care, and you also never know what's coming in the door.
Yeah.
The second you think things are going smoothly, you could have somebody who's very, very sick and a big problem quickly. But we're RTs and we know how to handle it.
That's it. And all bets are off, and you just adjust. So
Yes. Yep.
I'm sure you're faced with lots of challenges, probably almost daily. But can you think of a particularly complex challenge that you faced anytime recently or the past?
Oh, sure. Yeah. So in the pulmonary function lab, we also do cardiopulmonary exercise testing. So that is analyzing breathing, heart rhythm during maximal exercise. And then in our lab, we do what's called an invasive cardiopulmonary exercise test that also includes a Swan-Ganz catheter in the neck going into the right side of the heart,
Mhm.
and an arterial line looking at blood coming both from the lungs and from the heart. So we had this very young girl who had experienced quite a bit of shortness of breath and some lightheadedness with exercise. Pulmonary function tests were totally normal. They sent her on to cardiology. They did a stress test. It was totally normal, but she's an athlete, and you really do need to push an athlete to absolute maximum to see what's going on with them. Um, there were quite a few people who were interested in her case because, like, why is this athlete having such a problem to the point of almost passing out when she was doing her exercise, which she wanted to do daily, and we want her to do, and we want her to do it safely. So we brought her into an invasive exercise test. So she went to the cardiac cath lab and had a resting right heart catheterization with the Swan-Ganz catheter in the arterial line, and then we brought her in for the exercise. Again, the pulmonary function part was totally normal. We put her on a pretty aggressive ramping protocol, which means that we make it harder pretty fast because we wanted to see what was going to happen. So she actually was a research patient, so we were drawing extra blood to make sure that we were getting all the data, and she was doing such a beautiful job, like a really clean test. And I don't know why. I just happened to look over my shoulder at the machine as I was drawing some blood. We were approaching what's called anaerobic threshold, which is the point at which your body produces more carbon dioxide than it does exhaled oxygen. And um, we were supposed to draw some blood at that anaerobic threshold. So I look over my shoulder, I see she's approaching it. I let the team know she's approaching it. Right before I turned back, I saw her heart rhythm go from a normal sinus rhythm, tachycardic, but that it was normal for the amount of exercise that she was doing, into supraventricular tachycardia, like that. Like I saw the
Wow.
beat that it happened. Immediately, I look up at her And I said, "Are you not feeling well?" She said, "Yes." Um, so we stopped the exercise abruptly. There was a cardiology fellow who happened to want to just watch the test. He grabbed her on top of the bike, grabbed her neck, and started a carotid massage right there. We safely lowered her to a stretcher. She did not lose consciousness. They we were able to break that supraventricular tachycardia, get her on a Zol just in case any other rhythm were to come about. And once we got her all situated, she was conscious through the whole thing. I said, "It's okay, you're safe." And she started to tear up. And I was really worried that she was scared because that all of a sudden we went from very quiet, very calm to immediately getting to her stretcher. And she said, "I'm not crying because I'm scared. I'm crying because you guys will finally believe me that what
Yeah.
I experience is real." And I said, "Oh, your experience is very real." And it made me scared for her that this was potentially happening to her at like a gym. She was
That's
coming out of that rhythm on her own, but that could be something that could be the person who drops at the gym or on the soccer field or somewhere else. We actually were able to capture in that test. We pushed her to a threshold. We saw what happened, and now we can meaningfully intervene on her problem so that then she can safely exercise again. So I'm actually this happened relatively recently, and I'm actually hoping she comes back for another exercise test so we can see how much better she does.
nice. And that really highlights, I mean, that's a great example of, it not only highlights your background and in
Mhm.
acute and with pulmonary function and the testing in the lab, so it's all kind of combined, but also your work with other medical professionals in
Mhm.
the hospital. So how often does that come into play, and what is sort of your relationship with some of the other specialties and pulmonary?
I find it very rewarding to work alongside with nurses and pulmonologists on a daily basis. Many times in the hospital setting, it's because of the nature of our work, and we go in and we fix a problem and we leave. We're not able to always, as respiratory therapists, establish great relationships with pulmonologists. They're on different rotations. We see them for a week, then they're gone. In the pulmonary lab, we work consistently with pulmonologists. We are communicating with them directly about the results of the test. We're on a first name basis with most of them. I always say they can spot us in a lineup, right? We even when we are on the floors, they know our names. They work with us closely. Um, we also, when we work in this exercise team, we're working directly with them on the same patient, very similar to something like a bronchoscopy. We're part of a team that's working with the same patient. So it's very rewarding in diagnostics and pulmonary function to be able to communicate directly with the provider and to advocate for the patient, one on one.
It's great to hear that there's so much teamwork, and it really does take sort of the village to really in all of these a lot of these cases.
Hmm.
So I guess you had mentioned early on sort of someone who would help mentor you and sort of piqued your interest of to getting into the respiratory care profession. Can you think of any other mentors who have helped you along the way in your career growth?
Hmm. Oh, definitely. So I've been very fortunate to work with my director in respiratory therapy, respiratory care at Yale New Haven. So I can give a shout out. Mike Nay is my director, and he is a very quiet but inspirational leader. That he gives me a lot of room to be able to grow, not only as a professional myself, but as a lab. He lets me innovate and bring new things into the lab, and also to grow my team, and is very supportive of the things that I may need, the resources that I need to do so. You don't always see that with your direct leadership, and I do appreciate everything that he does to support sometimes my harebrained ideas of new things to bring into the lab. um, and I also I have mentors and friends really within the pulmonary function world. I've been very fortunate to work alongside Carl Mottram and Ralph Stumbo, who are some of the biggest cheerleaders of pulmonary function. And you can call, text, email anytime, and they will give you so much information. I also, I'm a big fan, and I have gotten to meet Jeff Haynes. I'm an enormous fan of his PFT tutor on YouTube.
Yeah.
I've learned so much from his CRCEs that he has on the AARC website. His podcasts or his YouTube channel is amazing because even if you think you're at the top of your field, there's always something to learn.
Yeah.
Always. And it's great that the community in diagnostics is so open and inclusive. Through AERC Connect, there's a constant daily dialogue of people asking questions and others chipping in their answers and what's worked for them in their lab. And that's amazing to have that community through AERC Connect.
I love that, and it's so exciting to hear that's helping, and that your connectivity within the different sections and connect is being of help. And I will tell you just from experience that the diagnostics community specifically, oh my gosh, it is like just full of information. And to your point, just you don't see responses, your questions going unanswered. It's sort of like your mentors, they're just jumping in almost immediately with answers, with help, sort of helping us, supporting each other within this community, which is so exciting. If you were giving advice to somebody thinking about being a mentor, we just opened up, for example, a new mentor hub within AARC Connect, that will invite, of course, the mentors and then the mentees to come in to search for some help and guidance, maybe in their careers. What advice would you give to somebody who might be on the bubble, thinking, do I have the time? Should I mean, from your own experience, what would you say has been sort of top of mind in terms of deciding whether to be a mentor yourself?
Sure. I think it's about not being intimidated by the term mentor. So you don't need to know everything. You don't need to have done everything, and you don't need to be at the end of your career to consider yourself a mentor. So I think it's about willingness to work with others, to learn with others, and to just take the approach of we're here to find answers and provide guidance without needing to know absolutely everything. I've had mentors that their immediate response to my question is, let me look that up. Like, let me see if I can find that for you in an easy
Yeah.
format. So mentoring should never be something that's intimidating. It is a partnership.
That is great advice. And to your point, it's not meant to be somebody who could just do all, know all, be informed of every section. So that is great. And it sounds like you've had some great help along the way. I know there's a lot in everything that we do. There's so much new technology coming down the pike. So what are some ways that what are some things that you're seeing, and what are some ways that you stay on top of the new advancements coming around the bend?
I try to stay very current with meetings that are going on, whether it's ATS, ERS, ARC meetings, new articles that are out there, and new innovations that are happening. Many times when my providers return from ATS, I have a line outside my door of all the talks that they went to on new things that they want to now provide at our lab. We definitely like weigh the pros and cons, but technology and software in particular in pulmonary function is what's making it all happen. Um, if if there is software that can interface with your electronic medical record to your devices, that's what's going to make it easier, because RTs, whether they're in the pulmonary lab or at the bedside, the most difficult part, and probably the part that weighs on us the most, is documentation. So you did all the things, but going back and writing it down and making sure you had everything there, the more interfacing that there can be for our devices so that the RT can focus on the person and the patient and making sure that they're getting good quality data, whatever that interface is that can then send it on to the places it needs to be without needing to manually transcribe or print it out on a piece of paper and bring that paper somewhere that can get lost, right? For all we know. Um, that's the innovations that are going to make doing this testing and making sure it's more accurate so much easier for the bedside clinician or the person who's doing the testing in the lab.
Sure, and I imagine that has to do a lot with just the connectivity,
Mhm.
lessening the duplicative work, AI, a lot of
Mhm.
picking up maybe a little bit of the slack, just better communication all around. So that's
Mhm.
that's that's great to hear.
Yep.
Sort of looking, I know you're not in a spot to be doing this right now, but sort of looking back at your younger self, what advice would you have as some of the challenges that you might have faced early on as a student or an early grad? What advice do you have for your younger self?
I think it's just to always try to stay as positive as I can towards the field. So we all have ups and downs throughout our life and throughout our career. And I always, if I could go back to the new student, just not listening to any negativity coming from others, whether it's within our own profession or, because that was just, it was fog. It's things that hold you back from, don't go for that promotion. Don't go for that thing because what's it going to do in the long run? Don't go to the PFT lab. That's not acute care. Um, all of those negative messages as a young RT you can take to heart, and it will just impede your growth. Take the opportunity to do the other things, to take a per diem somewhere doing something completely different in a different age group. You never know what you're going to like. And the field of respiratory care is so broad. There's so many things that you can do. If you don't like one thing, try something else, and it could completely change your life.
And to your point, it's highly personal. So what
Yeah.
somebody might be saying to you in their own opinion about something may or may not resonate, and maybe very different for you. So that's great advice.
Mm-hmm.
Looking just specifically at diagnostics, what has been, I guess, what do you think is probably the most rewarding thing about getting into this specialty?
I think the most rewarding thing always for me is being able to see a patient through their care and something that you're able to provide them that's meaningful and improves their life. So, whether it's a diagnostic test that tells them they have something wrong that now a provider can fix, or seeing a patient through a lung transplant
Mm.
and having them come back and have incredible results from those new lungs. Even in cystic fibrosis, when modulator therapy became sort of the forefront of how they treat cystic fibrosis, those first pulmonary function tests would bring you to tears to see somebody go from so impaired to a whole new outlook on life because this drug has changed the dynamics of their breathing, and it's measurable and it's meaningful. um, that is just so rewarding. And we get to see people across lifespans. I've been now in respiratory care for 20 years, and I do tests on children that I took care of in the NICU. It's amazing to see them become an adult who's going to college, who is going to have a job, when they were just this tiny preemie that you didn't know was going to survive
Yeah.
back then. You do remember them. In the pulmonary lab in particular, we're speaking to them by their name and having a conversation. You remember that stuff as they continue on with their testing throughout life. So the patients are always the most inspirational part of what we do.
I love that. And I think you have that continuum of care within diagnostics where you
Mhm.
really get to follow sort of for a while at least their progress and get to know them. So that's really exciting.
Mhm.
If there was one thing that you could change about the profession, it could either be just in general respiratory care, respiratory therapy, or diagnostics specifically. What would that be?
I think it's our presence in the community, how we're perceived even on television. Have you ever seen a respiratory therapist on television? Um, we're constantly at the bedside making meaningful interventions. And we are the ghosts of the healthcare industry.
Yeah.
Um, we I would love for us to be at the forefront of whether it's a medical show or we were on a poster right next to a nurse, right? We're right alongside everybody else.
Yeah.
Um, I feel like sometimes in diagnostics, we do get a little bit more credit, at least by the patient, because they're able to say thank you. How many times does a bedside RT hear thank you? Like
Yeah. Yeah.
1 in 100, 200 times. We do hear thank you more often in the pulmonary lab. But I think that we really need to be out there so that people know about our profession, so that students, whether it's middle school, high school, college students, can make the choice to go into our amazing field. They don't even know we're here.
I love that. I love that. Yeah, again, I just really want to thank you for coming on today and for your great insights and just sort of, again, talking about some of the significant relationships that you've had with others in the field, in your specialty, patients, and just sort of some of the choices that you've made along the way. It's really exciting. Just to sort of, and again, thank you so much for being here today. I much appreciated. Thanks for your time. Just wanted to give you all a heads up that you can see Marjorie again on September 17. We're going to have a webinar at 6:30 p.m. It's going to be presented by the diagnostics section, and it's on tips and tricks for spirometry quality. We're here, spirometry quality. And just a quick note, you do need to be a section member to join, but we hope that those of you watching will check it out. I think it's going to have some great information. And again, thank you so much for joining today. We really appreciate it.
Thanks so much. And just remember, if you want to join the diagnostics section, I'm giving a plug for the diagnostics section. You can do so in your regular membership. And then if it's in between membership, you want to join, you want to be able to see our podcast, you can always call the customer care department. It's actually a very quick call at 972-243-2272. And they can add you to the diagnostic section so you can be part of our regular conversation.
Awesome. Hey, thanks. Thank you for the plug-in. I appreciate that.
Thanks, Monique and Marjorie, for joining us today for this informative AARC Perspectives Behind the Breath podcast on respiratory care diagnostics and the importance of mentors. As Marjorie said, just a reminder that if you aren't a member of the diagnostics specialty section, you can call our customer care department at 972-243-2272 or email us at info@aarc.org. Thanks so much, and keep an eye on your inbox for details of the next Behind the Breath podcast. Take care.
Thank
Thank
you.
you so much.